Okay, good afternoon, everybody. Ready and energized after lunch? Well, if you're not energized, if you feel a little bit sleepy, we got a very good panel, the last panel of the day before we give the word to our guest speaker for the closing keynote. And it's going to be a panel about white spaces. So what are the gaps in this integration journey? Integrated care, collaborative care, what are the white spaces and how can we fill those white spaces? And my colleague Silvia is going to be the guest for our panelists. Silvia?
Thank you, Max, and good afternoon, everyone. So this is the final workshop, and guess what? We're talking about integration. I think that all the panel today, especially the first one, address how integration is the connecting tissue between personalization and greater efficiency industrialization. But Professor Hamelung in the first panel asked us, okay, if we all agree that integration is so important, why isn't it happening? Well, as this wants also to be an IT conference, by the way, we know that information technologies is key to provide the infrastructure for information sharing, collaboration, but we understood that this is just part of the equation. We have people, so physicians, patients, caregivers, and the process, how we do organize all this integrated care pattern. And within this panel, we try to bring all these three perspectives and hopefully trying to find some common grounds to spur integration. So the first panelist is Dr. João de Deus, who is here as president of the Association of Senior Hospital Physicians in Europe, and he's also a practicing physician in Lisbon, Portugal. So please come join us. Then the second speaker is Arve-Olav. Solumsmo. Arve is an independent ICT consultant, has been working 25 years with healthcare IT, trying to match the requests of the physician and the possibilities, the opportunities of the IT departments. And finally, our third panelist is Jeni Bremner, who is the general manager of the European Health Management Association that will give us an understanding of what integration means from an organizational perspective, from a policy perspective. So, Dr. João de Deus will give us a short introduction on his views on this important topic, please.
Some slides. You have the slides, please. Thank you very much. So, first of all, I want to thank the organizers for inviting me and my association for being present here, and I will try to keep on the 10 minutes of communication. So the challenge that was made to me was integration between primary and secondary care and how the new technologies can help on this. We know that in Europe today we have some general and some specific problems. We have different countries, different health systems, different hospital models, different problems. And some specific like privatization of hospitals, the high technology, the expensive treatments, and we know that hospitals are always a good target for cost-saving measures. And now we have a panorama in Europe with financial problems and with economical crisis, but we must never forget that our aim is patient safety and quality of care. So besides this, all these problems and all these crises, we must focus always on patient safety and quality of care. So integration, is it important? Well, we can see in Europe and I bring this slide of Jeni's organization. Integration in health and healthcare, it was made in Portugal in Porto 2 years ago. We see this article from The Guardian that says lack of integrated care. It's from December 2012. And we see that yesterday and the day before, there was a conference in Istanbul about secondary care provision for more integration and better health outcomes. So we see that is an up-to-date question. So integration, is it an impossible mission? Well, I will give you the example I know better in Portugal. In Portugal, we had, till some years ago, old health centers and hospitals, and the doctors from one and other of the institutions were really back to back with no communication, no integration. And now we have changed. First of all, we have changed the traditional GP for a family doctor with new skills. Not all these skills that I had this slide from Mozambique, next colony of Portugal, and the African traditional doctor from Malawi. It solves all the problems: social, business, job, love, marriage, etc., etc. So the new family doctor is not all this, have not all these skills, but now is on the center of the process, is connecting with the social problems of patients, connecting with the hospitals, connecting with the new units of tertiary care, with the new units of continuing care, and they are organized in family health units, new buildings, and they are in the center of the process. So in the old days, the traditional general practitioner will send, when he asks for an opinion of a specialist, send the patient to the hospital, and the patient goes by his own to make the appointment. The consequences is lots of days of work that are lost because he goes to the hospital to make that appointment. There are no priorities, and a waiting time very long for 6 months to 1 year to get a consultation in the hospital. Nowadays, the family doctor, we introduced the high-tech technology, so it's called the alert system. So the family doctor will introduce the patient on the system, and it goes directly to the hospital. The benefits are no working hours lost for the patients to get the appointment. There are priorities in the attendance, and we have a balanced waiting time. How does it work? It's very simple. The family doctor puts the patient on the system. In the hospital, the people who is responsible sees the waiting time in hours when the patient is in the system. Then he sends to the doctor that is responsible on that specialty for make the appointment, and this is the doctor. The doctor will see who is the physician who sent the patient, where he comes from, what family health unit he came from, and then he will see the clinical information. Only the doctor can see the clinical information, and when he sees this, he can see also what medication the patient is having, what are the complementary exams, analysis, and so on, and then he will establish the priority. And that means that it can be a normal priority, so in maximum of 90 days, 3 months, you will have an appointment, a consultation. If the priority is high, it's 60 days, and it's very high, in a maximum of 30 days, you will have the, the appointment, the consultation with the specialist. And so the work of the doctor is done, and this is very useful, and this integration has been very useful for all. So when the doctor goes to his consultation in the hospital, he enters on the patient, and then he can make the clinical record, so he writes the observation. He will prescribe by e-prescription the medicines, and he can also make the schedule for a new consultation immediately and give the patient the new date for a new consultation. So, of course, this is not the perfect system. There are still questions and problems that we have. But the old questions that we have, should family physicians go to hospitals, or should specialists in family go to family health units, these are questions that we do not put anymore. But of course, there are problems to solve. I mean, the access to clinical records. The access of clinical records is blocked on the institution. So I can see everything that is written about my patient in the hospital, in the different specialties, but I cannot see what the family doctor wrote in the clinical record and vice versa. So this got to be solved. We don't have also a feedback from the family doctor, and the family doctor don't have a feedback because the system is not yet integrated. So we need to improve also the integration with tertiary care and continuing care. This is the article yesterday of the Telegraph that give elderly proper care, GPs told here in UK. So we have to also improve all this. So in the future, we know that in Europe, now we have a lot of immigration because the countries that are in deep crisis, people are immigrating to other countries, and we have the new directive on cross-border, so we'll have more and more patients going to treat abroad. So we need some electronic record, clinical record, so that the patients could be treated better. And so what is the solution? We are discussing in the European medical organizations and also in the European Commission if the solution should be an electronic card. We'll keep that for the discussion. We'll have what should be on the electronic medical record. Because if you put all the data, you get lost on that. So you should put there only the main problems, the medication, the allergies. But why not, if you have these new technologies instead of an electronic card that must be read everywhere, why don't use the mobile technology? Why don't use the smartphones to have these medical records there, and the patient could go anywhere, and the main information of his situation is there. So I think we'll keep that for the discussion, and thank you very much.
Our second panelist, and he will explain how do you procure IT in a future-proof way. It's a big challenge, but certainly is part of the problem and the solution.
Thank you. Now, this event sort of ruined my presentation because I was getting new impressions and ideas and thoughts all the time. So I completely, I have too much to say and etc. But they promised that they will kill me at exactly 9 minutes and 59 seconds. So we'll go. So I'll just answer this question immediately to make sure that I touch it. Yes, it is possible. Can we do it the way we are doing it today? No, we can't. We are just like the man that's climbing up a pole and is telling everybody he's on his way to the moon. Technically, he's correct, but he's not going to get there. And I'll get to that. Now, when I talk about integration, we are talking integration on different levels, and this is sort of the outline of the speech, that I will talk a little bit about infrastructure. You need a solid infrastructure, and I'm not just talking equipment, I mean design of infrastructure to support the applications that work together. The reason why the applications should work together is so that you can exchange information, and hospitals want to be paperless. Some of them have forgotten why. The you want to exchange information so it can support processes. And unless it supports processes, it doesn't work. Now, to me, integration in digital hospital is wider than what we've talked about here. It doesn't just include the clinical space. It includes the facilities. These are some of the most expensive real estate and advanced buildings. There's a facility management part of it. You have kitchen, you have cleaning, you have equipment. There's a medical, of course, that's why it's there. You have a communication space, not just for the clinical communication, but again for all the support for students, visitors. And you also have an application space. You need orchestration, the ability to change and upgrade applications without having to walk around and do an installation on each of these PCs. So this is the framework and this is something that we requested in the project I was working in Trondheim in 2003. You might have seen this from some supplier. I've used their graphics because they're better graphics artists, but this is what we told them to supply. If you've seen it from Microsoft, it's to have a solid or stable infrastructure and then an agile applications work on it. And this is sort of the complexity of the space. Typically, a hospital, from my experience, personal, 150 to 400 applications that they support. If you have more, you are going into a management problem. 20 to 50 types of devices that you plug in, not just PCs and telephones, etc., but all kinds of portable equipment that needs to identify itself. Completely virtualized, so you can, because that's the only way you can be both secure and send and prevent that if some idiot medical student sends a half a terabyte image by email, that doesn't collapse the rest of the system. And in St. Olav's Hospital, we did about 100 general integrations, technical integrations, like nurse call goes to phone. You can call an elevator by using a phone, etc. But as the project went on, I also saw that to the hospital, integration was only clinical integrations. And so you need, and you should, if you want to solve this from an architecture point of view, you need to have, this is the way we do integrations. But what typically happens is that you get integration packages, maybe for each applications, but certainly for each type of space. And that's not quite going to do it. Now, in the last 10 years since that design, there has been some changes. So one of them is this, that medical equipment that used to be in one place and be equipment becomes portable, and it becomes IT equipment. Now, these doctors are so incredibly enthusiastic because this microscope has two features that have come in the last 10 years on all clinical equipment. It is the wheels and an RJ45 jack. That used to be a microscope. Now it is a software implementation. It used to be in that room where you put it. Now you don't know where it's at. And this equipment, this is, we're shooting at a moving target because this proliferates. And you thought maybe I was going to talk about the tablet here, but that was old hat 10 years ago. Stethoscope becomes electronic. That's an ultrasound machine. That is actually an electrocardiogram. The most downloaded and third most useless application in the UK, a colleague told me. But at the same time, you maybe have your phone with you more often than a stethoscope. So these are, this is also the reason why you need a proper design, because this will happen. The next 10 years will do something similar. I don't know what, but you still have to account for it. Now, applications. Healthcare approaches applications also in a kind of strange way. I'll tell you, in 1988, my wife came home from her work at a local bank. with the news that, that their IT department had decided to make their own word processing because there were, neither WordPerfect or WordStar was able to do the kind of difficult thing to send out letters to about interest rates, etc. Well, I wasn't much of an IT consultant at that time, but I knew that was wrong. The project stranded 6 months later because the different departments couldn't agree on where the tabulator stops should be. And of course, nobody knew that Microsoft Word would come along, but still, that was not a good idea. Now, hospitals typically have this approach to a lot of their equipment. Across Europe, in some countries, up to 1/3 of the EMRs that are implemented, and you can see there in various degrees of implementation, but 1/3 might be in-house development. But if you discount that, there is in each country about from like 8 to 15 suppliers, and they're different in all the countries. And what that tells me is that they are not supplying solutions. This is not industrialization. You think that Epic and Cerners and Chipsoft, etc., provide you with EMR as a solution. They do not. They are selling customization. They are selling and living off making adaptations because each one hospital buys their own separate. In the previous one, we were told that, yes, I work much with my supplier. The iPad you have at home, how much did you work with Apple to make that work? Absolute zero. It was industrialized. It was working out of the package. And that's what you need to do in order to have EMRs that will work. Now, why don't they work? Well, this is an image from Life magazine in '94. 98 people were involved in a heart bypass. Now, this is integrated care. It's just hard to do. You can see this is what I call medicine, providing medicine. This is actually 96 people providing information for the 97 people, the surgeon, so that he can treat one patient. A much truer picture is this. Patients go through the system, and all that matters is really that we talk about is the quality, the quantity, and the speed of that process. Anything else does not contribute to healthcare. This is providing healthcare. And errors and delays in the system do occur between these. So we had the Intel presentation yesterday, the Saturday morning epiphany, completely correct and also slightly misleading because it was highly efficient for him. He could see that this was so much better. Does it affect the patient flow? Unless it provides more healthcare, it doesn't really affect the total system. We also talk about lowering costs. We don't lower costs. There is a price level that we have in each country, and the matter is to make most efficient healthcare within that cost level. Cost level in Norway is much higher than it is here in the UK. They have the same concern. It's not because they're more or less efficient. It is how much we think we can afford. Now, the health record have a tendency to reflect this kind of situation that we think of, that staff treats patient with equipment that generates record. The real situation is much more like this. And that's where the difference between practicing medicine and providing healthcare comes out. This is a systemic thing. We need to provide an efficient system for providing it. Luckily, IT does have an effect. This is a study from Paris, and it's on the effect of hospital production. Now, if you want to increase production, sensation, if you hire more people, that will do it. And that is the most effective. Capital investments, like building a new OR, is going to be the second one. And IT will be about, IT investment can explain about 7 to 10% of the increase in 17 hospitals in Paris in this period. However, if you hire 10 doctors, it has a certain effect. If you hire 10 more, it has slightly reduced effect. And what he found also is that with the IT investment to generate and integrate the information, if you spent $1 million on that, you get a certain effect. If you spent another $1 million, you got slightly more effect. So there's the curves go the other way on those two. Now this is a typical hospital workflow, as you can see. This is from NHS 2006. One of the difficulties that we have in it is that we have a tendency to do exactly this when we integrate. We follow these paths instead of changing the workflows. It is known, this is from the 90s, and it's not from hospitals, but it was when everybody first bought PCs, and you went from 20% of people in companies having PCs to everybody having it. And the world did not change, and they wondered why. And this is a study that found that if you invested heavily in IT without new work processes, you actually became less productive. If you changed both your IT investments and your work processes, you became more productive. That's a little bit on, it's a little bit like to say you throw a man a hammer. Some people build a building, other people drop it on their toes. But unfortunately, it's also true. I think it's true for healthcare. Thank you.
So, Jeni, how do we make to build this house?
Right. Well, I want to start with some general remarks, and these are some of the things that we've heard a number of times during today, and I believe also yesterday. And I think the first point I want to make, that in many countries, we're in a very unenviable position in that we have healthcare systems and organisations that are largely unsuited to the needs of the growing majority of our patients. So we've got a real mismatch between what we've got and what people need. We have a workforce that is increasingly specialised. We did some work recently on health professional mobility, and part of that was trying to work out how many doctors were moving. And what became very obvious was, what's a doctor? And in some countries, there are over 60 subspecializations of doctors. So there's a lot of specialization. We become very sophisticated with much greater in-depth knowledge and technology, but often related to single diseases, which can make seeing the whole picture much more difficult. The leadership, support and development in our health systems is very hospital-centric in most countries, with very little investment in leadership in the primary care setting, and in many countries, very low levels of knowledge and understanding of actually what primary care is doing and how good they are at it. There's big knowledge gaps. Many countries are also using market approaches to improve efficiency. And while that can bring benefits, it can also make collaboration and integration more difficult when you're working in a system with inherent competition. And as the chief executive of the hospital, your job is to keep that hospital going, and irrespective of what it does to the guys next door. So within that context, when we think about integration, can we integrate across the whole health system? Yes, I think we can. You can do almost anything if you put your mind to it. I think the question we need to ask is, how desirable is it? What's it going to deliver for us? And there's a risk that when we're talking about integration, it becomes almost an end in itself and a kind of panacea for the ills and the difficulties we're facing within our health system. That if we could integrate across the whole chain of healthcare, if we could bring in social care into our mix, we could begin to sort everything out. And I think it's critical we remember that integration is a tool. It's an approach. It's not an end in itself. Many of the differences in outlook and approach between different bits of the health system and between health and social care are significant and sometimes valuable. So when we're thinking about integration, we really need to understand and acknowledge some of those differences and work out what the value and importance of them is when we're developing integrated systems. And if we don't do this, and if we don't do it well, we're going to meet high levels of resistance and all kinds of red herrings. We're hearing earlier today about the red herring of security and information sharing. And I worked before joining EHMA at a policy level in England, and we were looking at integrating children's services, and it was the big problem. But actually, it's a red herring. It's a much more complex problem about how people see what they do. And never, ever, ever underestimate the ability of a large organisation or a system to resist change. It is astonishing how they can resist change. So faced with that, how do we begin to do it? Well, to really deliver effective integration, I think you need to build a very clear vision of a way of working and a distribution of responsibilities that all the key stakeholders can understand. They understand the purpose and the goal of what's happening. They can see where they fit within the integrated system. They can accept what's happening as good for patients. And importantly, it's a system and an integration where they can feel comfortable working and which they feel stimulated by. We must not forget the importance of our staff in this. Too often, I hear policy discussions particularly where it's about we've got to increase productivity, we've got to push people through the system, we've got to make the staff more productive. The happier and more content the staff are, the more likely you're going to get a good patient outcome. And there's a big piece of research study called RM Forecast that shows across 15 plus countries an absolute correlation between the job satisfaction of nurses and the patient outcome. It's totally correlated. It's a massive, massive leadership challenge. So where do leaders fit in this? Well, fundamentally, I think the job of leaders is to begin these conversations, to get the key stakeholders around the table, get the conversation started and manage the conversation through to the end, given that that can be 5-10 years away. It's helping to develop the vision across the organisation and the professional boundaries. The work within the organisation can be as complex and difficult as work across organisations. And it's understanding what technology can do. We've heard a lot about what it can do in terms of sharing information, in terms of actively involving patients in their care, tracking progress and results, supporting integrated care pathways and new ways of delivering care. So in conclusion, we need to be clear about the purpose of the integration. We need to develop a very clear vision and to be realistic about timescales. This is not quick work. This can take a number of years. Never forget that one of the most key stakeholders is the political stakeholder, and that's local, regional, or national, depending on your system. Political leadership and support can absolutely speed up these processes. And finally, when you've done this, and potentially if it takes you 10 years, you may have spent, I don't know, 25%, 30% of your career working to deliver this integrated system. Just don't expect too much congratulation.
So you've seen 3 different points of view that actually converge in a sense. So any question from the audience? Don't be shy. I know you are. Please, is there a microphone somewhere?
I'm a clinical commissioner in the UK. My question really kind of following on from what Jeni said around leadership. And I was just interested, and also around looking at kind of integration in social care as well, is around models of collaborative leadership, which I think we need to be able to understand much better to be able to do the job, to be able to bring everyone together. That was one point. And the second thing, I absolutely see the kind of what you were talking about in terms of the culture and the buy-in from the staff. And I wanted to, whether there was any advice. I've got, we're in a very challenged hospital trust locally. There was the announcement yesterday of some injection of money for winter pressures in the UK. And usually it's kind of, money is distributed out amongst most of the hospitals and most of the health systems in the UK, and everyone gets a small bit of money. But this year, some very challenged trusts have been allocated quite large sums of money, and our local trust and our local health economies have been given kind of a fairly large sum of money to be able to look at doing something over this winter period to stop the A&E waits and everything else. And I have a meeting next week with some local consultants, local hospital consultants. It's been a trust where culturally they've been bashed and they're demoralised. These are a group of new consultants who want to do something for the future. What's your advice around how we can engage them in some of the leadership needs that we're going to need to take forward over the next few years?
Okay, first on the collaborative leadership. I mean, one of the things I didn't talk about particularly was governance, sorry, because I was told to do that. That's where political support and a good policy framework becomes quite important. And that so partly it's about having your policy framework, but it's also important to look at the performance management of the different players in the system. Because if you're performance managed against different targets, inevitably you're likely to be pushed apart. So finding ways of performance managing in terms of patient outcome or in terms of shared targets can be really powerful and really help with that kind of collaborative leadership. Because then it doesn't, problems aren't just the problems of one organisation, they become the problem of the system, and you can work together to help solve in the best case scenario instead of kind of chucking bricks at each other, so you're not doing very well. What you do with a group of new consultants, particularly in an area where the service is not valued or has been heavily criticised, I think is challenging. You've got, if they're new, they're going to be energetic and willing. And I think my first suggestion would be have a talk with them about what they think, presenting what the profile of the area is. So this is patient population, this is a demographic of what you're serving, these are the problems that are coming up, these are some of the key players. How do you think we can begin to take it forward? And engaging in some of that conversation, because that can also be the beginning of building up that vision and then beginning to pull other people into those conversations. There's some really nice examples around engaging with citizens and communities. There's a model in the west of Sweden, in Gothenburg, that's been incredibly powerful in changing the health-seeking behaviour of the citizens, but also in turning a hospital that nobody wanted to go near and work in to one of the most prestigious and most desired places to work.
Would you like to comment on that as well?
Yeah, I have very general one do and one don't. The don't is that I could see in that situation that it would be very tempting to get, it's dangerous to get rushed into we have to do something quickly, it's more likely that there will be a flash than that there will be a bang out of that. The do's is that I think that if you can find something relatively small, quick and visible, and there must be something that they have thought about and then postponed because they didn't have time or funding, and now you have funding, but that it's small and manageable and visible, so that you can get a success. And because it's very important that you get a positive spiral going, because like you said, if you start throwing bricks at each other, then you'll have blood on the floor and broken windows, and so you need to get something positive going, I think.
Managing the short term and the long term.
Yeah.
Just a comment. Also, in my association, we are very committed with doctors' involvement in management, because when you are a head of department, you must be a leader of a team, but also you must know you have to have some skills about finances and to deal with the financial constraints that you have nowadays. So, for instance, in Portugal, the Portuguese Medical Association made an agreement with the university, and we have for 1.5 years doctors that get skills on that area of management that it's very important in different levels of the hospitals.
Any other question from the audience? Yes, please. Just wait a second for the mic.
You would have heard earlier that I work for an organisation that provides care in the community. And I talk to hospitals who provide care for my patients for 10 or 20 days in a year. And they talk as if that's their healthcare. But for 340 days of the year, they're receiving care outside of the hospital. And your presentation has been about hospitals and health, but for those 340 days, they're also receiving social care. And that's where the key challenge of integration is, because in social care, their funding models and their measurement models are about funding whole years of care. They put in a care package for a long period of time. And we in healthcare tend to put in a lot of input for a very short period of time, quite expensively, and then try and get people stable again. So the problem we have in our system is how do we get our own ICT, our own business intelligence and information management systems in health, which are about spells and charges, to match up with the care system, which is actually about the complexity of care packages going in every day, day in, day out. And then when do you end that care package and when do you assess it and step it up and step it down? So it's just to encourage people to think more broadly about not the hospital's care and health, but actually the rest of the year and the complexities we have in integrating across that in particular.
Arve.
I think you also hit on a very key point on reimbursement. Norway is doing a health reform at the moment where the hospitals are funded by the government, while GPs and community care is funded by the municipalities. And they're trying to switch it so that the money will follow the patient. So not just in these two pieces, the 20 days and the 340, but that there will actually be a funding for the entire thing. And that is very difficult. It's difficult both. The technical challenge is the smallest one. The organizational challenge is quite big. The bureaucratic challenge is absolutely enormous. But it's part of what I said. That is being patient-centric, is to actually physically follow the patient, to do the things happen that you want to happen. Unless that's the case, the system is flawed. Sorry.
Two things. I think one, we've heard a lot about more care at home, and there's a very significant assumption there, which is that the home is fit to receive care in. And that is not always the case. The homes people live in are either functionally not fit for purpose, in that they may be too difficult for people to get around and not possible to be adapted, or they may just not be very good homes.
Maybe a lot safer than a hospital.
Disease-wise.
Disease-wise, potentially. But I think that's one element. I think the other issue, particularly around social care, is that the workforce providing the care at home is part of the lowest paid workforce that we have, often illegal in many countries, and often paid for privately by the families or by the individuals. So it's not always part of the rest of the system. So it can be incredibly complicated to join it up. I think between health and social care, and for 10, 12 years, I worked representing local government and social care nationally. and fought off many attempts, and many health colleagues here might take me outside and beat me for this, to integrate social care into health. And I think my perspective on it is there are fundamental differences between how health and social care see things. And I think the best analogy is if you're in hospital and the toast is soggy, who cares? You're only there for 20 days. If it's your home and the toast is soggy, that's the rest of your life. You've got to live with that. So it's a very different way of seeing and valuing things. And what's needed, I think, is not forced organisational integration, but actual finding ways of working across those organisational boundaries, because there'll always be organisational boundaries, and we've just got to get better at sharing information across them and working, respecting each other's differences across them. And on one level, it's an incredible generality, but I think it's also incredibly challenging and true that that's what makes it work better.
Yes, you're completely right. In hospitals, we treat patients 20 days a year, and the rest of the time, it's the social care, or as I show in my slide, we have the tertiary care, the continuing care, and all of this must be integrated. That's why it's so important to make all this integration for better outcomes. And as you said, in Portugal, we are trying also to do that politics. The money will follow the patient. As far as I remember, this was a policy introduced by Margaret Thatcher some years ago in the UK, and then was abandoned. But it's, from the point of view theoretically, it's a very good starting point, because wherever the patient is, the money is there for treating the patient. Social, continuing care, hospital, wherever.
We had, there's of course an underlying assumption that typically in hospitals that patients are better off in the hospital than outside, but most people don't really want, you know, it's, of the 10 things I want in life, going to hospital does not even get on the list. You know, I'd just as soon not go. I'll go if that is what I need and it's safer, but I'd rather not.
Can I add a comment? Because
sure.
In our my organisation has 25% of its mental health beds that it had 10 years ago. Because it became a matter of social justice that we had to close those beds, because we were taking people into hospital that could be treated at home and could live in the community. And I would argue the same argument holds for frailty. That elderly, frail patients are taken into hospital almost against their will, where they're over-investigated, they're exposed to disease, and often their levels of mobility dramatically deteriorate to come home again. And if we use the same social justice argument, wouldn't we be saying that frail elderly people deserve to be treated at home? And let's re-engineer the system to enable that to happen.
Well, I have a study from Trondheim where they found that for geriatric patients or above 70, that is, shorter stay increased their 12-month survival rate. And so if you kept them more than 5 days in a hospital, it was an active risk. They estimated that in the before they made a study, about 200 people in Norway die unnecessarily because they're kept in the hospital a little bit too long. And you can see that you're old, you're frail, you're sick, you're in hospital, and you go, oh, so that was it. Okay, I guess it's that was the end of the road. And you know, it's physical, but it's also mental, and it reduces their ability to move, but it also reduces their will to move. Now, if you're released into appropriate conditions, that turned out to also be a factor, like you said. Don't send them home just to send them home. They might need a nursing home in between. But if you can have appropriate facilities to get them there as quickly as possible, increases longevity.
I mean, I think what mental health services have done, particularly actually in the UK and in England, is a real model for rethinking how we might think somatic care in the future. And the mental health services have divested themselves of most of their beds. They have very integrated community care services. They have gone through the pain of getting multidisciplinary teams working effectively with nurses leading as well as physicians, and there's a lot we can learn.
Okay, there is time for just one last question. Okay, so I think that we covered pretty much the theme. So thank you to all our panelists for your great contribution. And now it's the stage to our closing speaker.